Thank you, Michelle. I think, as you point out, these challenges that we face are not ours alone in the US. And the one thing that's clear from the 1918 pandemic and every disease outbreak that has followed is you can't build walls to keep yourself safe. That is possibly the worst strategy. And in fact, what we need is much more engagement and cooperation and people working together, because that's how we move this ball forward. I'm going to introduce our keynote speaker, Allan Brandt. He's the Kass Professor of the History of Science and the Professor of the History of Medicine. Allan has done extraordinary work, written several books on the ethical and social aspects of disease and health. He's a former dean of the graduate school, and he wears many, many hats, but I'm going to just quickly mention one that is particularly and personally important to me, which is he chairs our faculty steering committee. And that may be a small role for Allan, but for me, it's extraordinarily important. And I can think of nobody I've learned more about global health from than Allan. He has changed how I think about it, the issues that underpin it, and the historical aspects that have gotten us to global health in the 21st century. So when we thought about an event where we could think about the historical lessons from observing pandemics and epidemics and what that can teach us about how to do this better in the future, it was pretty obvious that we needed to get Allan here. So Allan Brandt, thank you so much for being here.
Ashish, thank you so much. What a fantastic introduction. Also want to thank Dean Williams for setting up so many of the critical questions that we want to look at today. I just have to say, I'm so excited about everything happening here at the Harvard Chan School, and the Harvard Global Health Institute has really, as Dean Williams said, been such a great opportunity to bring people, students, activists, advocates, faculty together across the university on what are really not just the epidemic problems of our times, but the epic problems of our times. So I'm incredibly honored to be able to kick off this session of what is just a spectacular week of visitors. I was looking at the list and I just thought, oh my gosh, I have to teach this week. What am I doing here? So anyway, I just wanted to recognize the importance of doing this and also say the importance of thinking historically. And that's really one of the cases I want to make today, is that we have real opportunities by thinking deeply historically, not just to reflect on the past, as we will about the devastating 1918, 1919 massive epidemic pandemic, but also to think about how we can really utilize historical thinking in the ways that we observe disease in the present and think about it in the future. And that's really the goal of, I'm going to try to run through a fair amount relatively quickly, but I wanted to, I've spent my career really trying to think about observing disease. How do we do it? How do we think about it? What's really going on? Certainly from a material and epidemiological perspective, from a clinical perspective, and patients and families that are suffering, but also from the perception that these meanings of disease, which we can recover historically, have a gigantic impact, not only on the way that we understand earlier societies and cultures and politics and health and science, but also on the material outcomes for patients and populations. So what I want to try to do is just indicate very quickly this strategy and then how I see it potentially speaking to the question that Dean Williams raised, which is how could it be, and we think about the 1918 epidemic when microbiology was in its infancy. There weren't really schools of public health. Hospitals were still considered sometimes more dangerous than safe or helpful. How can it be that in this day and age, pandemics are so powerful again? And how can it be that our infrastructure is so inadequate to address the fundamental human questions of our time. I was very influenced by two books early in my career. One is Charles Rosenberg, who's my distinguished colleague and friend here, his book, The Cholera Years. I assume many of you have read it, but Rosenberg did something very brilliant. And I wanted to say he did this as a graduate student. This was his doctoral dissertation. He wanted to understand American society and culture in greater depth, and he was exploring ways to do this. And he became aware that there had been three major cholera epidemics in New York in the middle of the 19th century, and all had hit New York City especially hard. So he argued that what this really created was a natural experiment. There was the first epidemic in 1832. Really, the ministry and religious leaders led the response to that epidemic. They said we should fast and we should pray. There was very, very little understanding of what had brought cholera and even less understanding of why the epidemic ended. In 1849, there was another epidemic. Now physicians were somewhat more powerful. They had began to propose theories of why New York City was suffering from this very high mortality associated with cholera. They talked about quarantine and detention, keeping boats in the harbor, some things that would work, some things that would never work. And then in 1866, there was the third epidemic. And what Rosenberg really argued, if you looked at these three discrete epidemics, same disease, today we understand same organisms, you had seen three societies, all in the same place, respond in fundamentally different ways. Well, the 1866 epidemic, even though no one had looked at the cholera vibrio, led to the beginning of industrial infrastructure in American cities. There was the founding of the New York Metropolitan Board of Health, the first real organization. It predates public health schools. There was the beginning of the idea that we had to develop technologies of clean water, and they had to be for everybody. So when we look at infrastructure, the cholera epidemics of the 19th century led to a tremendous, perhaps just in terms of competitive dollars, one of the most intensive capital investments in infrastructure that we would ever see. And ironically, I've been thinking about this as I was preparing for today. And when you see what's happened in Flint, Michigan, it was the infrastructure built in the late 19th and early 20th century that we did nothing about that produces toxicities and disease that were really addressed around the time of the major flu pandemic. So these are some of the ironies. Rosenberg really taught me how to observe disease. He had an argument that if you observe disease closely, then you could understand a society and its polity and its economics at any moment in time. But as I did more work, I began to realize that actually there were potential insights for modern medicine and public health, and we could scrutinize these processes of disease meanings and then utilize those understandings of what a disease means to understand not only its material impact, but what we might do about it. And the other book that really influenced me was Illness as Metaphor, because it sensitized me to the language that we use to talk about people who are sick and how that language can be harmful, especially to patients. Susan Sontag, when she wrote it, was suffering from breast cancer. She really felt harmed when people said, you know, the war in Vietnam is a cancer on the American body politic. And she sort of said, block that metaphor. This is not the way we want to be talking about disease and using it as a metaphor. I'll come back to that in a little bit. So we have the early history of the HIV epidemic. I found myself, having worked on sexually transmitted infections, that there were a lot of sort of these literary and cultural observations. The reference you see in this slide, it says, all people with AIDS are innocent. I'd read articles in the New York Times that constantly referred to children and women as innocent victims of HIV, people who had utilized the blood supply. Brilliant sort of construction on the part of AIDS activists. The notion of silence equals death, the work of advocates, the formulation of new groups like ACT UP, really had a fundamental impact on rethinking what appeared at the beginning of the epidemic, and it's hard to get back to that moment now, that we were about to live through one of the most oppressive and reactionary moments in the history of American public health and probably world health. We began to attend early in the course of the HIV epidemic to the problem of infrastructure. This was a report done by the IOM, 1988, 5 years into the epidemic. And this report, if you go back to it, says, we have failed with our public health infrastructure. We're not surveilling disease adequately. People don't have adequate access to treatments, often which are now effective. We've often thought about public health as not really including the provision of care. It said the US system is crazy because on the one hand, we have national infrastructure for public health, but it's really totally contingent on investment at the state level, and that the states had authority in most instances over the national government's policies and approaches to public health. So this is 1988. Now, as the epidemic went on, the AIDS epidemic went on, there was growing concern about the rise of infectious disease again. And it's really quite striking when you think back to 1918, because the United States had been relatively free for 75 years from massive epidemic, communicable, transmissible disease. And it had been a remarkable period of relatively good health in the West. But now there was the notion that these were microbial threats that really needed to be rethought. And they, of course, they emphasized infrastructure. The best way to prepare for the future is by developing and implementing preventive strategies. We know that. And so one of the things I really want to suggest is that we really have to figure out what we know and why we can't use what we know, as opposed to continuing to say, well, we know what to do. So the question really is, if you know what to do, why can't you do it? And that's really the heart of what I want to suggest this afternoon. They came up with recommendations: improve the US public health system, more research and training, very unobjectionable, very important, but not really accomplished in the context of the early or the AIDS epidemic then, or in many instances now. It was followed up, and this is really the beginning of the logic of global health, that there were global pathogens. They would not respect national boundaries, that we really had to figure out ways to connect and collaborate. In other places, I made the argument that AIDS really invented global health as we know it, and that the regime of international health, and you see both perspectives in this report, because it sort of says, how are we going to protect ourselves from the world? Wait a minute, we're in the world. And that's been one of the dilemmas of infrastructure and epidemic disease since the early AIDS epidemic. Now, I've been watching sort of this strategy, like how are we to think about emerging diseases more recently and what we do, and the problem of infrastructure, along with Dean Jha and others. I followed closely the emergence of the Ebola epidemic in 2014. This is a kind of iconographic photographic image. I think these photographic images were incredibly powerful. They communicated certainly the risk, but also they engendered a kind of fear and the ominous character of the epidemic. Having trouble there. Here we go. Sorry, let me go back a minute. This was kind of characteristic of the discussion in the American media, which I followed closely. This idea that Ebola is the ISIS of biological agents. This was a serious discussion on CNN. And there's this way, well, we could critique the sort of popular media in a moment of fear and hysteria. But of course, we know that Governors Cuomo and Christie closed the New York, New Jersey Port Authority from flights coming from West Africa, even though all the evidence showed exactly what Ashish said in his introduction, that walls and quarantine and changing flights was not going to address the incredible and tragic problem of Ebola in West Africa. I made this slide at the time when I put it up 3 years ago, and it said Donald Trump rips reckless New York City Ebola doctor demands Obama resign. People sort of laughed. I've sort of noticed we don't laugh anymore about this. But it represents a view that I think makes more complex the problem today, which is that issues of nationalism, sovereignty, undermine all of our strategies and our plans for really utilizing public health in successful ways. These are characteristic photographs. One of the things I've noticed, and you see a lot of photography of epidemic disease in our current age, and I think it constructs meaning. I was very impressed by a news photographer who early in the AIDS epidemic went around photographing people who were suffering the very severe consequences of HIV infection. And he realized that the photographs were in themselves stigmatizing, became concerned about what he was doing. And he developed a program where he could get a lot of cameras and take them to the places that he had photographed. And he gave them to individuals who were infected. And he told them, tell your story, take photographs of yourself and your family. And it inverted this process of making meaning in the way that, regrettably, we've become so familiar with. But you can see how these photos, especially in the West, built anxiety, fear, hostility, and anger about the potential risks of Ebola. Now, this is an instance of failed infrastructure. Obama promised to send US troops to West African centers of the epidemic. He committed almost $1 billion. The idea was to send 3,000 troops as quickly as possible. It turned out that there weren't troops in the United States really prepared to go into an epidemic situation, and they trained at military stations in the US South for almost 3 months. Saying racing to get there, outbreak spreads, rebuilding these nations' healthcare systems. And then, of course, when the troops arrived in West Africa, the epidemic was fading quickly, and literally millions of dollars, thousands of troops, and getting deployed Ebola treatment centers that were never used and then were boxed up and brought back to the United States. And I've always seen this as the tragic illustration of the failure of infrastructure. If there was a military battle in the Middle East, we could scramble jets and have them there in less than 3 minutes. And with a tragedy going on the ground in West Africa, by the time the US troops showed up, they were useless virtually. And not only that, they had brought a lot of supplies. It showed that you could deploy some kind of infrastructure, and they bagged it up and brought it back to the United States. This is characteristic of, one of the tents that they built. So one of the things comes up, like, how do we explain this? Why are there these kinds of failures in contemporary global health and infrastructure? And one of the most prominent arguments is that epidemic disease is a perfect storm. And I've been thinking a lot about this because Susan Sontag had told me, be sharp to metaphors, how they're used and how they work. And one of the things that I've discovered is, like, when you look at Ebola, you constantly get this argument that was many things coming together. And when we talk about something as being a perfect storm, what we're really saying is it's unpredictable, it's idiosyncratic, you can't really plan in advance, and you can't really change the outcome. You can clean up afterwards, and that's kind of the notion that we've had about perfect storms. We saw a storm last week in South Carolina, North Carolina, Virginia, And that's kind of the model. It was very interesting. I have some friends who are tracking media coverage of the climate. And when Harvey struck Houston, exactly a year before, there was much greater news coverage that storms like Harvey were part of climate change. But tracking this in Florence, they found that very few of the major media addressed the question in relationship to the crisis, the tragedy, the response, that this is also a human-made, in part, phenomenon, just as Ebola is, just as AIDS is, just as the 1918 flu epidemic, which of course came after a worldwide conflict, and now we know much more about the relationship of conflict to disease. So perfect storms are generally adverse meteorological factors, or they're a bad or critical state of affairs arising from a number of negative and unpredictable factors. So everyone's predicting epidemic, pandemic diseases, microbial threats. But when we call these epidemics perfect storms, then we're undermining our potential for control, agency, investment in very powerful ways. This is a Zika baby, right away, the Zika pandemic, a perfect storm. The opioid epidemic, it would be hard to consider a more human-constructed epidemic of our time than the massive epidemic of opioid overdoses, more last year than in the highest year of mortality in the United States for HIV. 72,000 Americans died last year. And it tests many aspects of our infrastructure in ways that demonstrate its severe limitations. So come back to this notion, perfect storm turned to HIV from local to global killer. And I just want to suggest that the meaning that we make and our ability to observe it, and then our ability to really address those meanings and how they are constructed and how they can be modified, is really one of the crucial challenges facing public health at our moment. And I do think we can make great progress by realizing the inadequacy of national programs, sovereign boundaries, them, then us, the othering of disease that so many of these slides represent. So I'll end on a slightly more positive note. This is one of my favorite photographs. And what it really says, it's Jackie Ahmad, a very well-known South African activist, and Nelson Mandela. But when everyone put on the shirt that said HIV positive, it was an enormous act of compassion and connectedness. That's really what's fundamentally at stake when we think about outbreaks and infrastructure. So to get the kind of really effective and humane responses to disease locally and globally, I think this would be a very important place to look. Thank you very much.
So now you understand why I said I've learned more about global health from Allan than anybody else. Allan, that was extraordinary. Thank you. Let's take just a couple of quick questions before we bring our panel up. Questions, comments from anybody? I don't know if we have microphones, so you just have to, well, we do. So you just have to, well, you don't have to speak up, but please speak up anyway. Anybody? You're back there. Yes.
Oh, I was about to say, otherwise it could be loud. Okay, here we go. Amazing keynote. Thank you so much for that, Allan. Just a quick question regarding infrastructure kind of as it has evolved and will continue to evolve. What can we kind of as a scientific community, in your opinion, do to really help maybe with communication-wise in influencing our current government to make smarter decisions regarding infrastructure for global health, either even just on a national level, but hopefully for more like a worldwide level?
I think it's a great question. It's quite a difficult one in the contemporary political context. And I wonder about it sometimes because one strategy would be to say, you can be a Republican and you can be a Democrat, But these are human threats, and there are certain things that have cut across notions of our traditional political debate. And I understand the difficulties of this, but it's one thing I would try. One of my mentors was a former Surgeon General, Julie Richmond, and he started the Head Start program, which was highly politicized and difficult. But I once asked him, like, how did you do it? It was an infrastructural going to scale that we have hardly ever seen in the United States. And he said, you know, I never took no for an answer. We had to start right away because if we waited, the political winds would begin to blow. And he arrived in Washington in January 1964, and the program opened for 400,000 children that June. And like, this is just, you know, we sort of say, well, how could that be done? And what were the resources? And he had a very powerful notion, especially about children, that, you know, we can debate a lot of things, but when we talk about kids, everyone shares certain kinds of affect and commitment. So later, the program became incredibly politically, you know, contested, as these things do. But I think there are small and large things we can do. Like, I'm thinking a lot about processes of destigmatization, and do some small things work better than others? And I'm very impressed when I look at the HIV epidemic, how fast and far we actually traveled from a moment in which transmission of HIV was being criminalized. So to think by 2013, we got to a constitutional protection for marriage equality is a demonstration to me not to be so pessimistic as I often am.
And can I just build on that? Can I just build on that, Allan, by asking you, I mean, PEPFAR, like extraordinary investment, one of the most important global health interventions, I would say, of the last 20 years, done under a conservative Republican president, mobilization of massive amounts of resources very, very quickly. That has always given me hope that we can make these kinds. It's not infrastructure in the same way, it's treatment, but it's, so do you see that as one of the stories that give you hope that we can bring people together around really pressing problems? Or do you see that as sort of a one-off that is going to be hard to replicate?
I think all of these things are hard to replicate, but I look at PEPFAR much the way you do. And, you know, it's very interesting if you look at George W. Bush's legacy, it's at the very top of his political legacy and his identity as president, and he knows that. And there have been these possibilities, and, you know, timing is so much, and I think historians can give us greater sensitivity to timing. What can we do right now that might work? What would be great to do, but this is not the moment? And PEPFAR is really interesting. Much like Head Start, it became more controversial. It was more highly politicized later. My regret about PEPFAR, and this is one of the problems of infectious disease and infrastructure, is it was so focused on HIV that it didn't ask the question that we need to be asking about epidemic diseases. What can we do that will cut across notions of very vertical biomedical reductionist strategies? And, you know, we often sometimes chase our tails. Like, I'm very sympathetic to the development of vaccines. But the idea when people were suffering in West Africa with diseases that were really treatable by the technologies that we have, and we're saying, well, we really can't do anything until we have a vaccine, and we're going to speed up that process. If we did that each time a new epidemic comes, then I really worry. So I think we have to be much more strategic than we've been.
One last question, John O., and then we'll turn it over to the panel.
Real quick, thank you for that very vivid reminder that those who don't learn from history are doomed. Question: there's a real paradox. We haven't had, nobody's been killed by an atomic bomb in 70 years, but we never have problem funding and keeping going all of what we do for atomic preparedness and the Atomic Energy Commission. And in the last century, infectious diseases killed far more people in war, but we never had trouble getting gazillions for the military budget. And yet we keep seeing over and over again, as she's reminded us, this panic and complacency. Are there any lessons from history about how we can somehow keep this enough in people's minds that it doesn't take, decades to get things done?
I do think there are possibilities. It's really hard. Today, Donald Trump said at the UN, I'm against globalism, I'm for patriotism, and I was thinking, we have to realize that this isn't like a choice. This is the world we live in, and it's a risky world. And we could be much more secure than we are, and we could be much more humane than we are. And those are not self-evident, regrettably, so we need to do better in trying to make them that way. So
that's a great note to finish on. Al, thank you.